Welcome to lecture number 14 of the Cardiovascular section of the Integrative Systems Physiology course. Today we'll be talking about cardiovascular pharmacology, and our primary focus is going to be not only understanding the therapeutic utility of pharmacological interventions, but also placing them in the context of using pharmacological approaches to understand the pathogenesis of the disease and what's adaptive versus maladaptive in a variety of disease states to help us understand the physiology of the disease to a greater extent. And so to do that, what we will do is we'll be starting to focus on four major conditions in which pharmacological interventions are often used therapeutically and have lent tremendous insight into adaptive and maladaptive mechanisms in each condition. And the four conditions that we'll be focusing on are hypertension, heart failure, angina, so chest pain, secondary to cardiac ischemia, and then finally arrhythmias. So, with hypertension in particular, of course, we use antihypertensives to reduce blood pressure. And we say, well, what is hypertension? Technically, it is a systolic blood pressure that's greater than 140 millimeters of mercury and a diastolic blood pressure that is greater than 90 millimeters of mercury. And the causes of hypertension can be multifactorial, but we know that certainly can be caused by increases in stress. High sodium consumption is a major contributor in Western societies. Increases in vascular stiffness with increasing age. Certainly endocrine problems can be a substantial problem, as well as renal disease. So if you are having fluid imbalance issues or potentially hyperactivation of the renin-angiotensin system secondary to renal disease, that can be a major driver of hypertension. So the symptoms, unfortunately, in many ways, the symptoms are usually very mild. So the patients are usually symptom-free. They're usually diagnosed at the time of evaluation or physical or a checkup. And the consequences, however, of having long-term hypertension are quite substantial. And so there, with severe hypertension, you can certainly develop chronic heart failure. Chronic kidney disease or renal failure is a very common side effect of or consequence of having a high blood pressure there, because those increases in pulse pressure often result in end organ damage, certainly a cerebrovascular accident or a stroke, or hypertensive retinopathy. So there, again, the vessels within the eye oftentimes can be damaged by these long-term increases in blood pressure and ultimately result in visual impairment. So the potential drug targets are those that would make sense physiologically. So if blood pressure equals cardiac output times total peripheral resistance, there we would say that, well, we've got things that can modulate this central nervous system or autonomic nervous system, such as that would subsequently influence sympathetic tone, certainly influence the heart directly through reducing cardiac output or attenuating contractility. The veins, there you can certainly use certain interventions to reduce preload, and thereby reduce the force of contraction. Arteries, of course, reducing afterload on the ventricle and reducing the overall pressure induced by reducing peripheral vascular resistance. And the kidneys, of course, by increasing diuresis and inhibiting the renin-angiotensin system. There can be major mechanisms therapeutically to target that will ultimately improve both the functional and long-term outcomes in these patients. So when we start to look at these drugs in more detail, we've got really four major categories of antihypertensive drugs. We've got the sympathetic nervous system suppressors, direct vasodilators, renin-angiotensin system targeting drugs, and diuretics. So when we look at these in a bit more detail, certainly for sympathetic nervous system suppressors, if you will, their alpha-1 and beta-1 antagonists are very commonly used. And so they're drugs like propranolol, which is a beta blocker, or other compounds such as clonidine, which is a alpha-1 blocker. So those are drugs that can be used to both either reduce alpha-1 activation and reduce vascular tone, or reduce beta-1 receptor activation and reduce the contractility of the left ventricle, ultimately reducing pressure. Furthermore, alpha-2 agonists can be used to reduce vascular tone, but these I think are a little less common. So from there, then we've got vasodilatory drugs as well that can be used. So here we've got calcium channel blockers. So these calcium channel blockers bind to L-type channels. So now we're moving away from the sympathetic nervous system, moving more to a direct targeting mechanism of calcium regulation in the vascular smooth muscle and cardiac myocytes. So thereby regulating calcium entry into the cell and thus contraction of smooth muscle. Certainly what you have is blood vessel relaxation in there. By reducing calcium-induced calcium release in smooth muscle and calcium entry, you'll reduce vascular tone. With cardiac myocytes, of course, we know that the calcium-induced calcium release is a major mechanism influencing contractility and force of contraction. So that would be a calcium channel blocker would be a negative inotrope. So similar, these drugs also influence heart rate. So there's a decrease in chronotropic effect. So it's a negative chronotrope, and it also reduces conduction velocity, particularly at the AV node. And so here, again, the overall reducing overall cardiac output, reducing contractility, reducing the rate of heartbeat, and ultimately contributing to reductions in blood pressure. Dihydropyridines are also compounds that are direct vasodilators. So these are relatively smooth muscle specific or vasoselective, if you will, and these are drugs like nifedipine and amlodipine and other drugs. And so these have a primary side effect, however, of peripheral edema. So if you end up having vasodilation in arterioles and you're increasing the ultimate perfusion pressure in some of these distal capillaries, what you'll have is an increase in the exudation of fluid from the capillaries to the interstitium through the widening of that pressure gradient, the hydrostatic pressure gradient within the capillaries, ultimately resulting in significant side effects here. So that is a significant consequence of dihydropyridines. Now, there are other compounds as well within the class of vasodilators. So when we're looking at drugs that can increase vascular relaxation, so potassium channel agonists are a significant class of drugs. So here, as you would expect, if you're opening these outward potassium channels and blood vessels, you're going to get hyperpolarization. That hyperpolarization is going to be closing the voltage-gated calcium channels and ultimately reducing intracellular calcium. And of course, that sets off the series of events related to calmodulin and the phosphorylation of myosin light chains and reductions in vascular muscle tension generation. So therefore, you will have relaxation. And these are really only for very severe and refractory cases of hypertension because of course potassium is very tightly regulated ion in the body, and so giving too much potassium is generally not a good thing. An example of this would be in minoxidil, and the side effects of systemic minoxidil are hirsutism, so excessive hair growth. Of course, that's been leveraged in other ways with drugs such as Rogaine, and also you have significant reductions in blood pressure that are difficult to control using drugs such as this, just given their mechanism of action. And so then you end up having reflex sympathetic nervous system stimulation and tachycardia, and it can also induce significant problems with in patients with coronary artery disease. So, overall, it is just really, a complicated drug to use. And again, is therefore only used for severe or refractory cases of severe hypertension. Now, when we start to move more towards drugs that we've talked about in greater detail in the course, for example, with nitrodilators, so there, of course, we've got nitroprusside. So nitroprusside is metabolized by blood vessels to generate nitric oxide. And as we discussed in detail in one of our previous lectures, nitric oxide is a fantastic vasodilator. It's a primary endogenous vasodilator to reduce vascular tone. And by inhibiting calcium entry, it results in hyperpolarization of the cell and smooth muscle cell relaxation. So again, nitroprusside being a fantastic drug to result in very rapid vasodilation. Certainly, there's very rapid action as a result. Very short duration utilization is often used in IV forms for unstable patients. and nitroglycerin would be the sublingual version of this. It's got a preferential action on arteries more than veins. And nitroprusside per se is really only used in acute hypertension emergencies or during surgery for very tight control of blood pressure, given the fact that it's given intravenously and has very rapid on and off transient. So now, so let's move on to a different class of vasodilators. So now we're looking at targeting the renin-angiotensin system. So here, of course, as we discussed before, the renin-angiotensin system regulates blood volume, certainly blood pressure, and to varying degrees cardiac and vascular function. But this is a much more sluggish system as compared to some of these other systems that we've been talking about, because, of course, regulation of blood volume is not something that occurs acutely or rapidly. So, renin, which is released by the kidneys, there that results in sympathetic nervous system stimulation, renal artery hypotension, and it can also be induced by renal artery hypertension, and it can also be induced by reductions in sodium delivery to the distal tubules. So these are going to be your drivers of potentially increases in renin. So there have been renin subsequently acts on angiotensinogen. That's going to generate AT1, and of course, then ultimately, as angiotensin 1 goes past the vascular endothelium, particularly in the lungs and in the kidneys, you have angiotensin 1 going to angiotensin 2 via the angiotensin converting enzyme. And that is going to drive pathophysiology. And so when we're looking at angiotensin 2, that's going to constrict blood vessels, increase total peripheral resistance, increase blood pressure. It stimulates the adrenal cortex, stimulates the pituitary, facilitates norepinephrine release. All these things, and also directs cardiac and vascular hypertrophy, fibrosis, and remodeling. All these things are major contributors pathophysiologically to long-term increases in fluid volume, long-term increases in vascular tone and blood volume, which can be major contributors to increases in blood pressure. So, of course, one of the major targets then is going to be to inhibit the formation of angiotensin 2 and prevent that vasoconstriction, which of course, has effects in the previous slide. ACE inhibitors, as a side effect of the formation of angiotensin, prevention of formation of angiotensin 2 with ACE inhibitors, that prevents the breakdown of bradykinin, which is a vasodilator, right? And so by blocking that action, that also reduces afterload, right? So ACE inhibitors are that is again another mechanism, secondary mechanism for vasodilation. And the issue here is that bradykinin sensitizes airway nerves, and that can cause significant dry cough. So even though you're getting the prevention of breakdown of bradykinin by ACE, ultimately that increase in bradykinin is going to cause a significant side effect. These are all drugs that end with pril, so captopril, ramipril, enalapril, lisinopril. Those are all drugs within this class of ACE inhibitors, and the side effects here are going to be cough and potentially angioedema, right? So that cough is going to stem from bradykinin, and the angioedema again going to be stemming from the impact on the capillary beds. When we are looking at angiotensin receptor blockers as a potential alternate way to modulate the renin-angiotensin system, you can see that we're going to have similar functional outcomes as we did with ACE inhibitors. The upshot to this is that these do not impact bradykinin, and so you don't have bradykinin production, so you don't have a dry cough associated with it. And these are all drugs that end in sartan, so losartan, irbesartan, candesartan are all very popular and widely used AT1 receptor blockers, with, again, if you recall previously, the AT1 receptor being that deleterious receptor, 7-transmembrane receptor that's going to be driving increases in vascular tone. As for diuretics, as sort of final topic here, I think what we'll do is we'll just put this in the parking lot for a minute and discuss those in more detail in our sections related to heart failure, which of course is our next section here. So when we look at heart failure and the etiology of heart failure, of course we've got inadequate contractility or inadequate perfusion that ultimately results in the inability of the left ventricle and or right ventricle to expel blood effectively out into the systemic or pulmonary circulations. That results in a rise in venous pressure ultimately impairs fluid drainage. And so a lot of these patients end up having substantial pulmonary edema, substantial respiratory distress, significant lower limb edema when it backs up on the right side, deep vein thrombosis as well due to slower venous blood flow. And so overall, many problems associated with chronic heart failure. And the causes here, you can have idiopathic heart disease, you can have hypertension, myocardial infarction, heart valve disease, viral infection, many other reasons that it can be a root cause for the ultimate impact of reduced contractility, impaired cardiac stroke volume, and impaired cardiac output. So when we're looking at heart failure treatment, and we say, well, how do we manage these patients? The main ways in which we're going to be managing these patients are predominantly through diuretics and ACE inhibitors, and then a lot of the other drugs here. And then we're going to say, well, we want to fluid manage these patients, and we want to minimize increases in afterload, and ultimately optimize cardiac function if we can. So diuretics, ACE inhibitors, and angiotensin receptor blockers, glycosides in a very small subset of patients, vasodilators, so when patients have ischemic events and or ischemia associated with impaired perfusion, and beta blockers, as we discussed in detail. So when we're looking at diuretics initially, you'll discuss this in far greater detail in later portions of the course, but when we're thinking about renal physiology, the major targets here that we're looking at are loop diuretics that work here in the thick ascending loop of the kidney. We've got thiazides here again, preventing the removal of sodium chloride from the distal tubule, and in the collecting duct we've got this class of potassium sparing diuretics here, like aldosterone, which again inhibits the uptake of sodium, also prevent the extrusion of potassium here, that will ultimately all serve to enable the removal of fluid and increased urine production in patients with heart failure. And so this is a tremendously advantageous approach to managing fluid volume in these patients. So with loop diuretics, these are inhibiting the sodium potassium chloride transporter in the thick ascending thick ascending limb of the kidney, decrease sodium resorption and therefore have less water reabsorption in the collecting ducts with diuresis. Thiazides, those are inhibiting a sodium chloride transporter in the distal convoluted tubule, decreasing sodium reabsorption, very similar to what is done with other drugs, and of course with increases in sodium activating aldosterone and eliciting the reabsorption of sodium at the expense of hydrogen and potassium. So there, of course, you can have metabolic alkalosis and hypokalemia when these are given in excess. Now, spironolactone here, this is one of the potassium-sparing drugs. So again, you're going to be antagonizing aldosterone at the distal convoluted tubule. This allows more sodium to pass through the collecting duct, and the duct to be excreted, and prevents that aldosterone-dependent loss of hydrogen and potassium. So in many ways, this can be a preferred mechanism for augmenting diuresis in these patients without causing significant impacts on potassium levels and inducing hypokalemia. So when we look at other classes of drugs like the ACE inhibitors and angiotensin receptor blockers, so they're of course highly effective in heart failure due to systolic dysfunction. In particular, these can reduce afterload by causing vasodilation, thereby enhancing stroke volume and ejection fraction. They can certainly reduce preload, and that will serve to reduce pulmonary and peripheral congestion due to high filling pressures and excess fluid retention. They reduce sympathetic nervous system activation, as we discussed previously. So angiotensin II can have effects on the brainstem to augment a lot of this afferent input into the brain and ultimately augment sympathetic outflow. And they can prevent direct angiotensin II-mediated left ventricular remodeling. And so they're, of course, tremendously beneficial with regards to outcomes in these patients. Now, Shifting gears once again to cardiac glycosides. So cardiac glycosides, which we discussed previously, so those inhibit that sodium potassium ATP pump, so that increases intracellular sodium and slows that exchanger, thereby preventing the removal of calcium from the cytoplasm during that diastolic phase and increasing intracellular calcium, therefore allowing more calcium to be taken up into the sarcoplasmic reticulum and ultimately making this a positive inotrope, so you get increases in contractility. So this is a tremendous advantage, at least in the short term, although long-term treatment with cardiac glycosides often results in increases in mortality. So now, in addition to the direct effects here, they also, on cardiomyocytes, they can also increase vagal efferent activity of the heart and be a negative chronotropic agent. So that will be reducing heart rate through increases in parasympathetic nervous system outflow. And ultimately, those would result in hyperpolarization of the SA node and slowing in heart rate. So as we discussed previously, digoxin, Digitalis, those are particularly useful for a variety of patients with very severe disease, only really when patients are symptomatic, because again, as stated, there's either no survival benefit or a negative survival benefit. And of course, it accompanies with a risk of having digoxin toxicity, which of course doesn't do anybody any good necessarily. But even when used to avoid digoxin toxicity, usually the patients are sick enough and have poor enough left ventricular function that there's really no survival benefit here. So it's amelioration of symptoms predominantly in a bridge. Now, when we start to look towards other targets that we know are deleterious in the progression of left ventricular dysfunction and heart failure, beta blockers are one that, as we've discussed previously, they're predominantly used for systolic dysfunction with a reduced cardiac output. Again, as we discussed with samodorol, for example, it's very counterintuitive, but these drugs over the long term do substantially improve cardiac function because they inhibit the deleterious long-term effects of sympathetic nervous system hyperactivation. They prevent cardiac remodeling, they prevent apoptosis of cardiomyocytes, and so they're tremendously beneficial to break that cycle of impaired left ventricular function, increased sympathetic nervous system outflow, driving negative remodeling of the ventricle, and then propagating itself there. So it's breaking that cycle. Now, with anti-anginals, so again, angina being chest pain due to coronary artery disease or significant obstructions within the coronary arterial tree. So there, myocardial oxygen supply is less than the demand. And the treatment goal there is really to say, well, how do we increase supply and how do we reduce demand and ultimately optimize that mismatch that's occurring between demand and supply. And so there are three types of angina. One is stable angina, which is predictable, generally occurs upon exertion with increases in exercise levels or physical activity, and can be readily alleviated with rest. Oftentimes patients are prescribed nitrates or beta blockers, nitrates being a very rapid vasodilator to increase blood flow to those regions. Second is unstable, which is really with accelerating severity. Patients may experience just a sudden bout of angina while at rest and have chest pain at rest. They're very unexpected and can be prolonged. So again, here, patients probably going to be receiving nitrates. And then, this variant form of angina, which is almost always at rest, it's more associated with a coronary vasospasm, not necessarily with an obstruction that is more of a fixed obstruction due to atherosclerosis. But here, again, when you're looking at coronary vasospasm being a primary driver of this, what you would aim to do there is prevent vasospasm, very frequently done with calcium channel blockers, and so a very efficacious treatment for that patient population. When we're looking at anti-anginal interventions, nitroglycerin being the sublingual version of a nitric oxide donor that results in robust vascular smooth muscle dilation. Again, acts significantly on veins to reduce preload and reduce oxygen demand, and can also cause arteriolar dilation and reduce afterload. So it is beneficial in a couple of ways to reduce oxygen demand and not cause extraordinary dilation in arterioles. And this combination has been shown to be very effective. Of course, side effects here would be headache, hypotension, and tachycardia, and not unexpected with these. And that tachycardia would, of course, be secondary to the hypotension, resulting in baroreceptor unloading and reductions in the inhibitory signals being sent to the brainstem, as we've discussed previously. And of course, you wouldn't necessarily want to combine these with other vasodilatory drugs within the same class. So if you gave nitroglycerin as a nitric oxide donor, if you will, and then gave Viagra, which essentially prevents the degradation of downstream signaling molecules and nitric oxide signaling, there you'd have a quite substantial synergy between those two drugs and ultimately result in much more significant side effects. So modes of delivery here, sorry for the out of order animation here, but modes of delivery, certainly oral, sublingual, buccal, intravenous, and transdermal for a more sustained delivery method. Now, finally, when we're looking at antiarrhythmics, with antiarrhythmics, of course, arrhythmia would be an abnormal heart rhythm in some way, shape, or form. The heart, can pump effectively in some cases and less effectively in others. An arrhythmia can occur when the heart's pacemaker develops an abnormal rhythm, or when a conduction pathway is interrupted, or another part of the heart takes over as a pacemaker, such as an ectopic pacemaker. And the types of arrhythmias here are going to be, predominantly tachycardia, bradycardia, atrial fibrillation, and ventricular fibrillation. We've discussed all these before, but clinically having a definition of tachycardia being a heart rate greater than 100, bradycardia being less than 60 while at rest, of course. Atrial fibrillation being a very irregular heart rhythm in the atria, puts patients at very high risk of blood clots and thrombosis. And ventricular fibrillation, which is a tremendous life-threatening condition because you're not going to have the effect of pumping of blood out of the left ventricle. So when we're looking at antiarrhythmics with these sort of four classes of sodium channel blockers, beta blockers, potassium channel blockers, and calcium channel blockers, they're really targeting a lot of the main components of this action potential and subsequent ionic flux that's going to be driving the irritability and variability of ventricular and atrial signaling. So when we look at sodium channel blockers, the sodium channel blockers are going to block sodium entry during depolarization. That's going to slow that propagation of the action potential. This is particularly useful for a primary tachycardia because you're going to have slower action potential propagation and by default a slower heart rate. This is often used for atrial and ventricular arrhythmias. So the two drugs that are often used are like procainamide and quinidine, and so these two can be used to slow heart rate substantially and break some of these arrhythmias. For acute prescription treatment of ventricular arrhythmias, lidocaine can be used. So again, that would be the lidocaine, same lidocaine that you get when you go into the dentist or whatnot, but of course it can be administered systemically, and ultimately that can result in breaking of significant ventricular arrhythmias. And for acutely, but then for chronic treatment, there are other drugs that are going to be perhaps more stable sodium channel blockers, and those can often be used to prevent the induction of ventricular arrhythmias. So classes 2 through 4, if you will. So class 2, we've got beta blockers. So they're predominantly used for treatment of tachycardias, again, preventing that sympathoexcitation and increases in heart rate associated with the sympathoexcitation. So propranolol is an example of that. Class 3, potassium channel blockers. So these are going to be prolonging repolarization by blocking that outward flux of potassium, and oftentimes used to treat intractable ventricular arrhythmias. So there's a drug here called amiodarone that is often administered during acute cardiac life support for ventricular arrhythmias and ventricular tachycardia and fibrillation. So there, the upshot is that it probably will save you. The downside is that it's got a severe side effect profile and is not necessarily well tolerated over the long term. Class 4 are the calcium channel blockers, and those calcium channel blockers are going to be prolonging repolarization by blocking the inward calcium transient, and so they're efficacious in the treatment of atrial arrhythmias because of their activation at the effect site of at the atrioventricular node. And just a great example of that would be verapamil. So that would be a non-dihydropyridine drug. It's relatively selective for the myocardium, so you're not going to have a lot of off-target side effects that are causing vasodilation and other side effects that are really unwanted and poorly tolerated. So hopefully, just from a very high level, this has helped you go through some of the drugs that are commonly used to treat a variety of conditions ranging from hypertension to heart failure to chest pain to arrhythmias. And I would encourage you not necessarily to memorize the drugs, because I don't care that you memorize the drugs or even know the names of the drugs. I would say that most importantly, it is to think about how these drugs can be used to both interrogate the system and understand physiologically what's adaptive and maladaptive, because history has shown that we have done things to activate maladaptive pathways with the intent of trying to augment things, and in fact have done something very maladaptive and deleterious to patient populations, Zamodorol being an example of that. And then if you can think about these things in that context and ultimately dissect physiologically and pathophysiologically what's contributing to progression of disease, then ultimately that's more important than just memorizing some of these compounds and saying, well, I know that this drug hits that. If you can know that the class of compounds or the target that would be relevant physiologically, the target is, figure that out, then and know that it's viable, then work your way backwards to finding out what those drugs would be and specific compounds would be. But for the purpose of the course, again, I would say focus predominantly on physiology and knowing the targets that you think might be viable to preventing a lot of the side effects of these diseases. So with that, again, thank you for your attention, and we'll look forward to discussing this more in class.